I'm pleased to introduce our next speaker, Mitchel Maceda. Mitch is a board-certified clinical specialist in neurological physical therapy and faculty member of the Houston Methodist Physical Therapy Residency Program. He will be speaking on the topic of bench to bedside real-world challenges in stroke rehab. Mitch.
Thank you, Dr. Chu. Hello, everyone. My name is Mitch Maceda. Again, I'm one of the neurologic clinical specialists in physical therapy here at Houston Methodist at the Medical Center. On behalf of all the therapists tuning in this morning and all the therapists that see stroke patients across our system, we would like to thank the organizers for getting us involved in this activity today. As we all know, this is a slide directly from StrokeNet. Taking care of a stroke patient is a team sport. And there's been incredible work that's been done from the prevention side of things and in the acute treatment as well. However, unfortunately, some patients, or majority of patients, still end up with serious long-term disability. And it's, as a matter of fact, stroke is still the #1 cause of disability in the United States and across the world. This journey here from bench to bedside, it's been said it takes about 15 to 17 years. And there are a lot of challenges, especially in stroke rehab, considering that the realities of the bedside is very complex. It's hard to duplicate, the outcomes are very hard to measure, and even harder to define. The perspective that we hope that we can offer today is this complexity that we see when we work with our stroke patients in rehab every day. So I'll be talking about challenges from a therapy practice level, but with challenges also comes opportunities, both within therapy and beyond therapy. So first, stroke rehab is still very variable in how it's delivered. For instance, the dose that we provide in different settings, in acute care, in patient rehab, and skilled nursing, is very different. In acute care, it can range from 80 minutes to 180 minutes in a stay of 5 days. At least in inpatient rehab, there's a minimum about 3 hours. And in SNF, there's about 1.5 hour minimum. But it's important to remember that this minutes doesn't necessarily translate into intensity. In acute care, for instance, there's a very wide range, about 80 to 180 minutes. And this is just based on the availability of the patient. We know that therapy is not the priority in acute care, and appropriately so. A lot of patients are still doing their medical workups. So if they're not available that day, they can easily be missed. And all the hour minimums in inpatient rehab and skilled nursing, we all know that this is not enough to drive neuroplasticity. Along with the variable dose, the approaches that we do in stroke rehab is still very different. Traditional approaches like NDT or PNF and newer ones like Neuro-IFRA, these are still widely used and very prevalent in practice, more than we care to admit as stroke therapists. These are not proven to be superior than usual strategies. They're more kinematic based, but overall this provides a structure for a therapist to use when they're working with stroke patients. The second thing is our stroke therapists' use of evidence-based guideline is still very low. There's a study here back in 2010, but I would not be surprised if this would still be close to accurate today. Only 26% of neurotherapists uses research more than 6 times a month, and 25% rarely uses research at all. Our occupational therapy friends, I think, are doing better, that they hold a positive attitude with evidence-based practice, but not all of it translate to practice. But before we condemn our stroke therapists, there's a multitude of reasons for this. Not that they're not interested. The number one reason is time in the clinic. Our sessions also in our stroke rehab still lacks intensity. In acute stroke units, apparently more than 50% of the time is spent in bed, and 60% of the time the patient is alone, and 30% of the time, that's the only time that they're engaged in activity. And even in inpatient rehab, even though we're seeing them 3-4 hours a day, the intensity is still very limited. They require moderate to high level physical activity for them to improve functionally. And there are RCT, randomized controlled trial protocols that actually made it to bedside or close to bedside. But a lot of these are very difficult to implement. For instance, the EXCITE trial by Dr. Wolf and his group back in 2006, this was the constraint-induced movement therapy for subacute stroke patients. They've actually demonstrated statistically significant improvement with the upper extremity function. However, this was very extensive, 6 hours a day of task training, provided that some was done at home, but the amount of time that was spent with the therapist was still very incompatible with our outpatient clinical setting. Another example is the LEAPS trial by Pam Duncan and her group back in 2007. These are for subacute stroke patients. This was the bodyweight treadmill-supported training. They did 36 sessions, about 90-minute session each, a little bit lesser, but still hard to justify for reimbursement for a 90-minute session. A recent one, the AVERT study that was done in 2017 for acute stroke patients, this actually showed less favorable outcomes. But in my opinion, this was severely overdosed, 6 times out of bed sessions. This is 3 times more than usual care, that if this study would have shown some positive outcomes, it would still be impossible to implement this at the bedside. And lastly, realities at bedside. There's tons of things that we need to manage when we're seeing stroke patients. One of them is cognition. I think this is very undervalued and almost neglected. As a physical therapist, we always think about the motor system, how they walk, how far they walk, and they balance. And we don't totally understand how they're learning, how they're receiving information, how they're processing information, how they're recalling information. That at times we're teaching them a lot of things, new motor patterns, or relearning old motor patterns, and we don't consider their cognition at all. Mood also touches a lot of things in rehab. You can have the best plan of care. When you go into the patient's room and they don't want to work with you, then nothing really works. And it's not a secret that a lot of our stroke patients are not the healthiest before their neurologic injury, so we have to manage a lot of their comorbidities. We have to manage their blood pressure. Sometimes they have pain, metabolic abnormalities. Sometimes they go through dialysis, so that we need to manage their schedules and also their tolerance to activity. And also, a lot of these patients, they're not athletes prior to that they're ready to walk into the rehab and just go at it for 3 hours a day. So it's challenging to change their lifestyle in how they manage activity. From the therapy side of things, there's, again, other things that we need to worry about, but a lot of the limitations is time. All the systematic reviews and RCTs that was done, it always goes, the common theme is limited time. You can have the best clinician, the most dedicated clinician. There's only 8 hours a day, maybe 10 hours the most. Our managers here at Houston Methodist Medical Center are very supportive of us implementing new practice guidelines and interventions, but they too have to contend and operate within the constraints of our current healthcare reimbursement system. But with challenges, there are also opportunities that we can take advantage of. For those who are not aware, there are specialties now with physical therapy. One of them is in neurology. These are very experienced clinicians that has gone through board certification exams. They need to renew their portfolio every 3 years. I encourage you in your specific facilities, find these folks, connect with them. They'll be very happy to work with you, especially with stroke patients. Also here at Houston Methodist in the Medical Center, we have physical therapy residency and fellowship programs and occupational therapy fellowship programs. I've listed the program directors here, Judy Ragsdale for PT and Carrie Seamers for OT. They would be a good resource to connect for projects, just even to collaborate, or just to connect with them. Another thing that we do as we work with our learners through this fellowship and residency, and this is how we increase uptake in using evidence-based practice guidelines with our newer therapists. And this is one way too that we can really standardize stroke care from ICU down to outpatient. There's opportunities too for therapy and nursing collaborations. These are not new and unique, but just want to highlight the things that we're doing here. In our ICU, our nurses and our therapists work together. They do mobility rounds Mondays, Wednesdays, and Fridays. They try and assess and discuss who's appropriate to be seen that day, who's going to make it to the therapy list, so those who don't make it can be mobilized by our nurses, so nobody is left behind laying down for the rest of the day. We also have quality improvement projects that we've completed. For instance, this one here is a mobility card that's hanging outside a patient's room. So for instance, if you're walking down the hallway, somebody's trying to get out of the bed, trying to go to the bathroom, the alarms are blaring, you can go in there and help them appropriately, and you would know what type of assistance they need, what type of equipment they need. So instead of just stopping them from walking or going to the bathroom, you can actually help them walk to the bathroom. So we're not only implementing fall prevention strategies, but we're also encouraging mobility safety. And also, a lot of our new nurses that are coming in, they have orientation with therapy. So they follow a therapist for a day. They know what we're doing. They know our goals for the patient. So they understand, we both understand each other, so we can pull in the same direction. We always say this in our department, rehab is therapy, mobility is everybody. And to increase intensity outside of the therapy model, again, with the constraints of time that's usually outside of our control, we have to find other things to increase the intensity with our stroke patients. So we have mobility technicians in the stroke units. For instance, if I see a stroke patient in the morning, I talk to the mobility technician and they can walk the patient in the afternoon. We have walk programs too that we've implemented within our department. Some patients who are high level that has been discharged from therapy, we can enroll them in this walk program, and our own rehab technicians can go to the unit and walk them so they keep mobilizing while they're in the hospital. There are also knowledge translation models that has been proven to be successful. I've highlighted two here, one by Paris Group in Pennsylvania in 2014 and more in Norway in 2021. And a couple of critical issues here that they've highlighted for their success in implementation. One is administrative buy-in or support, interactive training, having clinical champions, using an implementation framework, and engaging the stakeholders throughout the process. One of the things that they highlighted was that education interventions in isolation is ineffective, and I think this is still something that we do throughout different settings. And lastly, if you have an opportunity to connect, work with your neurologists, your neurosurgeons, and basic scientists, translation projects are very important. Right now we have a stroke avatar app project with Dr. Volpe and Dr. Wong and the team, and Dr. Huddix with the vagal nerve stimulation. This helps us as therapists with the implementation. Not only that our perspective is considered in the creation and the planning, but we have direct access to them when it gets to that point that we're implementing this intervention. So it's a bi-directional translation model giving feedback back and forth. So in summary, definitely there's challenges, as I've pointed out. The stroke rehab delivery is still very variable. Our stroke therapists are not using as much evidence-based practice yet. The lack of intensity, RCT protocols are very hard to implement, and all the other bedside realities that we have to contend to. But I want to focus on the opportunities that we have. Our doctors Allied health professionals, our nurses, our basic scientists. Find your neurologic clinical specialist in your unit. Connect with the fellowship program in PT and OT and the residency program. They'll be very happy to collaborate with you. There's going to be always opportunities with therapy and nursing collaborations. And for our therapists, I would strongly encourage you to think about intensity outside of the therapy model. And use knowledge translation models for your programs. And lastly, and I strongly encourage our therapists to connect with your doctors, your neurologists, PM&R, neurosurgeons, basic scientists. I can confirm that they don't bite. They're very helpful, actually, and very collaborative. Thank you.
Thank you very much, Mitch. Your discussion of the real-world challenges facing stroke rehab are very timely. Dr. Hodich, who's going to be following you, her talk will include quite a bit of data on the recently published VNS Rehab trial, which showed that vagal nerve stimulation proved that it can improve clinical outcomes in chronic stroke patients with motor deficits. But the vagal nerve stimulation has to be paired with intensive rehab. My hope is that the evidence-based guidelines in rehab will change, will shift to incorporate the new emerging science and support intensive rehab, and most importantly, the reimbursement for intensive rehab. So is that what you foresee happening in the near future, and how is the physical therapy community preparing for this potential surge in the need for intensive rehab?
From a physical therapy standpoint, or PT and OT standpoint, we're very excited about all this new technologies that are coming out, for sure. But the limitations in the clinic setting is always about reimbursement, as you said, and time. What we're doing here, at least in Houston Methodist, having Dr. Hodich in place with what she's doing, and she's helping us translate this into real practice. And she's actually shown some of the things that her previous work about how she created the process that fits into the model of the clinic, that it doesn't take the therapist away from their usual routine. And she even mentioned that some of the things actually helped the patient's, the therapist's efficiency when they were seeing the patient. So if this products and this interventions, new interventions fits into that model, I think the implementation would be a little bit easier, and the transition will be a little bit smoother.
Thank you very much, Mitch.
Thank you, Dr.